All right.
Well, great. Looks like we have people joining us. Welcome, everyone, for those coming in.
Well, hello, everyone. I'm going to go ahead and get started just because it is at 9:30 and we have some stuff to get through today. My name is Robin Cruz, and I am the co-author of Making Peace with Your Plate, Eating Disorder Recovery. And I am the National Eating Disorder Recovery Advocate for Cato House at Integrative Life Center. And I am here today with the wonderful Tara Young, who is the Senior Director of Marketing. I want to thank Tara and her team for making this presentation happen today. You have been amazing in all your efforts, Tara, so thank you so much. Tara is also going to be the person helping us with all the technical issues. Fingers crossed we're not going to have any, but if you do have a technical issue, please feel free to put that down in the chat, and Tara will do her best to provide a solution. So today we are here for the paradigm shift, a new way to treat eating disorders and substance use concurrently. And Brennan will be presenting that. Today's presentation is sponsored by Cato House Integrative Life Center, and I'd love to tell you just a little bit about that. Bonnie, yep, thank you so much. Cato House is Integrative Life Center's women's residential eating disorder program at life centers. It is a residential level of care for women seeking lasting recovery from primary eating disorders. Treatment at Integrative Life Centers offers a range of services and clinical approaches, including group and individual therapy, experiential and somatic practice, family programs, psychiatric care, and medical and nutritional support. Cato House is a women's only healing haven located in the rolling hills of West Nashville. Upon assessment, each client will receive an individual nutrition and treatment plan to meet their unique recovery goals. It's okay. I know you're excited, Bonnie.
I'm so excited. Here we go.
Cato House is a part of Integrative Life Center, a trauma-focused treatment center in Nashville, Tennessee for primary substance use disorder, mental health disorders, eating disorders, and intimacy disorders. ILC offers a full continuum of care, including 4 residential programs, partial hospitalization, intensive outpatients, as well as detox and TMS services. I will say, if anybody is interested in learning more about Cato House, I would love the opportunity to share more about this to you. It's such a passion project of all of ours, and we just feel so passionate about the services offered there. So before we get started, I just want to do a little bit of housekeeping, a few reminders for CEs. For your attendance to be registered in Zoom, you must use the unique join link in your registration confirmation email. You must remain on the webinar the entire time. Join and leave times will be logged in Zoom. They sound very strict, but we don't make up the rules. You will need to complete the CE evaluation, which will be sent later today, only to those who stayed for the duration of the webinar. Certificates will be sent next Wednesday, August the 30th, and the webinar is being recorded and will be available to view on the Integrative Life Center website next week. CEs are not available for the viewing for the pre-recorded webinar. If you have any questions, you can contact this email here. I also want to just put out there that we are leaving time for question and answers. So if you have a question for Bonnie after our presentation or during our presentation that pertains specifically to the information within the presentation, opposed to, say, a technical issue or something of sorts, if you have a technical issue, you can put it in the chats. But if you have a question for Bonnie, you can go ahead and put it in the Q&A panel that you should see on the bottom part of your screen. So I would love to introduce to you the fabulous Bonnie Brennan. Just quickly, I've worked with Bonnie. I've known her for over a decade now, and it's been such an honor to continually be able to work with her. I will say off the book here that she is one of the most inspiring clinicians in regards to eating disorders that I know. She is always looking to shift our perspective on the way that we treat eating disorders. She's always working on herself and learning new information for those that she treats. And it's such an honor to be, to know her. So I will read this here. Bonnie Brennan, LPC. She is Certified Eating Disorder Specialist, CAI. Bonnie Brennan is a compassionate and mission-driven clinician. She brings her knowledge and leadership in the field of addiction, eating disorders, and mental health to her therapy services in Colorado, to clients of Integrative Life Center's Cato House in Nashville, Tennessee, as well as to families and caregivers using evidence-based interventions, groups, workshops, and continuing care models nationwide. Her advanced training in emotion-focused family therapy and acceptance and commitment therapy, as well as her experience supporting thousands of clients and their families at all levels of care, make her uniquely suited to transform the landscape of support for those seeking recovery. Bonnie is the founder of Eating Disorder Interventions and Bonnie Brennan Counseling and Education, LLC. Bonnie is a former leader of a large mental health care system for eating disorders, has been a licensed clinician for over 20 years, and is an engaging and compelling speaker. That is absolutely all true. And without further ado, I'd like to hand you over to Bonnie, who is going to be presenting today. Thank you.
Thank you, Robin. That was a lovely introduction, and I'm so excited to be here with everyone, wherever your time zone is. I know we have people joining us from the West Coast to the East Coast to internationally. So welcome, everyone. Today, we're going to take a little journey in a paradigm shift to understand and maybe think at a higher level how we want to treat individuals who present to us with co-occurring substance use and eating disorders, and maybe other things too. And I'll talk a little bit about that. So we'll first start with going over the prevalence and co-occurrence of eating disorders. I'll give you some statistics and substance use. I'm going to talk about why I think we need integrated care and some challenges that we have with the current way we treat these disorders, and identify some strategies for the treatment of eating disorders and co-occurring substance use. So just a little background too, why would I be so passionate about this? Well, as I started my journey in mental health, the first thing that I did was specialize in addictions work. And I would have people with eating disorders show up in my office all the time, not because I advertised that I knew anything about eating disorders. It was because I was assessing, without even knowing it, for the prevalence and maybe the evidence of maybe eating disorder behaviors. The reason for this was because I was raised by a mother with an eating disorder, and she had it her entire life, and she did all the things. She never got treatment for it, wasn't interested in changing, and in fact, tried to teach me how to have an eating disorder. Thankfully, I was so stubborn that I decided I didn't want to use her suggestions. And I even wrote a paper in college that said, the population, I will never treat eating disorders, because I thought, wow, I can't treat my mother for the rest of my life. So here I'd embark on my journey in treating folks with addiction, and I would start asking the questions about what happens when you try to abstain from your alcohol use or your substance use. And they would say things like, well, I don't know, I do other things. Like what other things? Do you find that you have a different relationship with food? What's your relationship like with the scale? And all of a sudden their mouths would drop open and say, nobody's ever really asked me about that before. And will you treat me? Please, will you treat me? And I would try to say, I don't have experience in that. That's not where I trained. Here's a card. Back in the Rolodex days, you take the card out. And maybe you can try this other person. And it was a number of clients, and I can see them in my mind right now, crossing their arms and saying, no, I don't want to go to somebody else. You understand me and you get me. And will you treat me for my substance use and my eating disorder? And, of course, I was like flummoxed. I didn't know what to do. So eventually I came around to the idea that the students essentially found the teacher, or the client found the counselor in this case, and advanced my expertise in treating eating disorders. And it's been such a good fit. That one of the reasons maybe is because I just have a radar and understanding due to the way that I was brought up. I can see, and I can appreciate that eating disorders and substance use have some similar things. And they're definitely different, but they're also similar. And I think we can harness some of the similarities by understanding the differences, and whether it's in an outpatient setting or a higher level of care, take advantage of a bigger context and how to help them. So a few statistics just for informational purposes. We'll be providing slides, so you can, if I don't hit all of these in details, you'll have these for reference. Eating disorders affect 28.8 million Americans. That's 9% of the US population. They have the second highest mortality rate out of any mental illness. Now, this was the highest mortality rate up until about 2018, when we were eclipsed by the opioid overdoses. So for those who have both opiate use and eating disorders, wow, they're really, they're really in need of our support. Women are typically diagnosed between the ages of 18 to 21. That said, one of my favorite populations to treat, and I run a group with the Eating Disorder Foundation, is for persons over 50 with eating disorders. They're a lovely population, and they really are true survivors in the sense that they've maybe learned to live and survive with eating disorder behaviors their whole life, and are cementing their recovery as they transition into their next stage of life. We have a higher prevalence of eating disorders in females than males. And 50% of eating disorder folks will be susceptible to a substance use disorder, so 5 times higher than the general population. And one of the things I've noticed in treatment is that sometimes we don't have the presence of a substance use disorder when treating an eating disorder, but it may pop up after a course of recovery as a different way to try to deal with the internal pain, feelings, emotions, and thoughts in the body. 30% of individuals struggling with a substance use disorder will be susceptible to eating disorders, and that's 11 times higher than the general population. So we have a lot of chances for these two populations to pick up the other disorder. The substances most frequently abused by persons with eating disorders: caffeine, nicotine and tobacco, alcohol, laxatives, emetics, diuretics. appetite suppressants and amphetamines, heroin, and cocaine. We have about 10,200 deaths each year as the direct result of an eating disorder, 1 death every 52 minutes. And another stat you can write down, I didn't include it here, is that 50% of all the deaths from anorexia are because of suicide. So what does it look like? What does substance use look like in terms of eating disorders? What are the prevalence rates? So we have co-occurring substance use with 27% of those with anorexia, 23% of those with binge eating disorder, and 37% with those with bulimia nervosa. And so let's make sure we understand what the eating disorder diagnoses are. And I've ordered these in the likelihood that we're going to see them in the substance use population. So bulimia nervosa, we have a characterization of a cycle of binging and compensatory behaviors such as self-induced vomiting and laxative abuse, exercise. They're designed to undo the food or the calories, so to speak. So there's the taking in of the food and the undoing of the food. Binge eating disorder is characterized by eating in a 2-hour period of time, the amount that is definitely larger than most people would eat in a similar period of time under similar circumstances. And in addition to this, there's a feeling of loss of control and intense guilt and shame over the consumption of the food. Anorexia nervosa, we're looking at a relative restriction of energy intake relative to requirements, meaning there's the amount going in is not equal to the amount going out. The amount going out is more. It can lead to significant low weight, but there are folks in larger body sizes with anorexia. This is all in the context of age, sex, developmental trajectory, and physical health. There's an intense fear of weight gain or becoming obese, even if the person is underweight, and even for those in larger body size will fear this as well, of getting bigger, and that bigger being out of control. And a disturbance in the way in which one's body weight or shape is experienced, an undue influence of body weight or shape on self-evaluation, or the denial of the seriousness of a current low body weight. Oops, I went the wrong way here. We also see other specified feeding and eating disorder. That is stuff that may have characteristics of eating disorder behaviors, but might not meet full criteria. So atypical anorexia can fall in either anorexia or OSFED, as we like to say. Binge eating disorder can also be a part of an OSFED diagnosis if it's not meeting the duration of time or the frequency of time. Same with bulimia. Some people have purging disorder, which is the purging of food, but it's not necessarily binging happening. So it could just be a regular amount of food and the person is purging. Or night eating syndrome, which is recurrent episodes of eating at night, awakening from sleep. Some of these folks are even in a dissociative episode and it's almost akin to sleepwalking your way into getting some food and eating. And oftentimes they don't remember having these episodes. This does cause a lot of distress too, because especially if they're in a shared situation with family members or friends, food may have been eaten and they don't remember. And so conflict and arguments can come up. Eating disorders have a bunch of other disorders that are usually present with them. In fact, I've never treated anyone ever that doesn't have another thing. So if they have an eating disorder, they have another thing going on. Whether it's anxiety disorder, you can see how high that is for folks with eating disorders, other mood disorders, impulse control, substance use disorder, any disorder. So we should be mindful of not just providing straight, whether it's substance use or eating disorders, just a straight treatment to address that, because the person has other things that they're dealing with. And unless those things aren't addressed simultaneously as best you can, they're going to be those triggers for returning to the behavioral episode of whatever you do with food or substances you put in your body to change the experience that you don't want to have. We'll get into this more later, don't worry. Some common traits are there's some similarities in chemistry, family history, low self-esteem, depression, anxiety, and social pressure. And one of the ways I like to break it out too is with understanding temperament. So Robert Cloninger was the developer of the Temperament and Character Inventory, which can be used to determine what is your temperament. And temperament is how you are before you have a chance to think about it. So it's the where your brain goes first, and in terms of how you react to things, you get information and input into the system. And then there are character traits. Character is stuff that you can change about yourself. So temperament fixed, character changeable. And for folks with eating disorders, they have high harm avoidant temperaments across all diagnoses. And what this means is that the harm avoidance is the extent to which you want to make sure that things are safe, you follow the rules, you don't want to get in trouble, you pay attention to the details. You can be very sensitive to being punished or rewarded. And it's hard for you. Oftentimes people who are high harm avoidant can also be really rigid about things. They like to keep to their schedule. This is one of the reasons in treatment settings schedules work so well. It's because if you post it on the wall, that it means it's expected to be done, right? And they have a characteristic also. So the temperament is high harm avoidant. It doesn't mean that these are individuals also who excel. They can take tests well. They're often the sons and daughters of doctors, lawyers, engineers, professions where you want to be high harm avoidant. You want your tax accountant and your architect and your attorney to be harm avoidant and make sure you're not going to get in trouble. So they can be genetically passed down to or learned within the family system. Low self-directedness is a character trait, and character is something that we can change. So low self-directedness describes how much that you direct your life based on avoidance of problems and pain versus wanting to do what's right for you, whether or not it comes with consequences or challenges or having to walk through some muck to get there, and what you want for yourself in the world, what feels right for you. So folks with eating disorders have low self-directedness. There was a study on this of over 995 eating disorder patients where we looked at all the diagnoses to determine this harm avoidance and low self-directedness. And the data was that all the diagnoses were over the 85th percentile for high harm avoidance, and then below the 25th percentile for self-directedness. So when you have low self-directedness, you tend to be more rule-bound. You're doing things because you're told to, not because it's necessarily right for you. You don't want to be in trouble or have pain and consequences. So all of your effort and energy is based on the avoidance of things. It causes you to have a lack of knowing who you are, for self-reflective ability, and understanding what you want your life to be about. Now, a little note on bulimia nervosa. Bulimics also have high novelty seeking. There is also a higher novelty seeking in binge eating disorder, not quite as high as bulimia nervosa, which means that part of their brain is saying, don't get in trouble, and the other one is saying, go out and have fun. So folks with novelty seeking, they're curious and adventurous. They can be impulsive, quick to anger. And all of this combines to have a sense of low central coherence. So missing the big picture about life and instead just following like what the culture has told us to do, what the family has told you to do, what the school system and so forth. And when we look at the same characteristic and temperament traits of substance use disorder patients, high novelty seeking is seen in substance use. So that's that temperament type that's impulsive. They might be spendthrift, curious, but they also have low self-directedness. So that's like the key right there. What can we do for folks with eating disorders and substance use is increase self-directedness. And I'm going to talk about some ways that we do this. Folks with a substance use disorder also have something else that we can harness, which is they tend to have higher self-transcendence. Self-transcendence is another character trait, which, if for all of us, the higher we can self-transcend, the more wellness in terms of what Cloninger's studies showed that we will experience in our life. So the ability to get out of our minds and think that we have to control for everything and worry about what we did in the past or agonize about what might happen in the future, and be able to let go and understand that there might be something out there, and it can be your religion, the way you see your universe, karma, whatever you have that's bigger than you and your brain, to help to let go and say, you know, I've done all that I can do. I'm doing the best I can. I'm going to do the next right thing for me and hope that it turns out the way that I want. And here's another place where we can insert helping both of these populations and build resilience so that I know no matter what life has to throw at me, whether it's taking me to my knees with joy or pain, that I can direct my life in a way that is meaningful and valuable to me. Okay, so I'm going to make it to kind of switch gears here and then tie everything together. So historically, we have had a challenge in the treatment of eating disorders and substance use because we have two camps and two types of ways of doing treatment that we would say start with one and then go to the other, right? And this can really lead to challenges. The treating in sequence, that's called sequential care, right? So treating in sequence, it may lead to whack-a-mole. And this is one thing at Integrative Life Centers. The inspiration for Cato House was based on seeing the prevalence of eating disorders that would show up to substance use treatment, right? And so while you're trying to get your sobriety managed, eating disorder behaviors may increase or vice versa, right? As somebody's trying to do their course in eating disorder treatment, they may be still having triggers, not wanting to use their behaviors and turn to things. And where I live in Colorado, we certainly saw this with when we became, legalization for marijuana would happen. And I remember I had a case of a young anorexic who, said that she was probably one of the first ones that I witnessed that went in to get a medical marijuana card for anorexia, right? Because she made the case that, this will help me with my appetite. And so, and then struggled with marijuana use as a way of dissociating and checking out. So symptoms not treated often interfere with progress. So if I'm trying to treat someone for an eating disorder and they're using that marijuana, it's not what we're trying to do with emotion competence or building a life worth living might be being sabotaged by the marijuana use or vice versa. If I'm trying to help someone in sobriety and they find their way into an exercise disorder, an anorexia, they might be just symptom swapping, right? And because of this, we'll have increased relapse rates. And there's a case to be made for integrated care. I have some references at the end of this where you'll see there's some some folks who have talked about this extensively. So we want to develop integrated treatment. It reduces cost for the consumer. The cost of treatment, as you all know, is not cheap. And being able to treat together might be more efficient. It can improve our treatment delivery. It can improve outcomes and it's time efficient, right? So that maybe somebody goes for an episode of care or in your outpatient practice, if you're able to wrap your arms around both at the same time, it helps the individual to be able to behaviorally respond to their life in a different way, while also building that competence with dealing with the painful stuff inside. And it's less confusing. One thing that is challenging when you have an eating disorder, you're in your body and you have to have food for the rest of your life. You can't just take away the body and food like you can with a substance. And so what happens is people tend to find different providers over the years. And if they've got both the substance use and the eating disorder, there's different ways of looking at the treatment for these. So maybe they find a 12-step community for the substance use disorder, and that can sometimes conflict with what we might be doing with eating disorder treatment, like messages. One of the big barriers that I've noticed over the years is folks get confused about like going to OA, for example, where there's support around overeating and addiction, but it might not be the same messaging they're getting for in eating disorder care. So it can be very confusing for the consumer to have the two camps divided. And I've just made this point, but I'll reiterate it again. We can't take food and body away from the person recovering with an eating disorder. And I remember I started in the addictions field, and one of the things that I had to also wrap my arms around was that even in a treatment setting with all the controls that we can put in place for an eating disorder, people still have eating disorder behaviors. We really can't take away the thoughts about the food and body, the difficulty with feeding the body and not wanting to problem solve it with exercise, your movement behaviors or purging or whatever they do. So in essence, eating disorder treatment helps us to think about ways to be able to not tolerate, but accept that the presence of the disorder is going to be there, and we'll have to be patient and understanding to move the individual to have willingness to let go and improve the behaviors that they might do, rather than that abstinence model. And this might be something that we think about in terms of substance use too. I know that there's lots of looking at this and folks out there, maybe even on this webinar, who take a harm reduction model in terms of an approach with substance use. And, so I would make the case also that eating disorder treatment is kind of a harm reduction model, right? Because we can't take away their substance. So where do we start? How would we start to think about integrating care and working to treat these folks with eating disorders and substance use together? Well, the big issue is with medical stabilization. And oftentimes there's not a place for them, especially in rural or remote settings, where they can get medical stabilization for an eating disorder and acute detox for a substance use disorder. So sometimes we have to make a decision of where to start in terms of a hospitalization. So if the thing that is distressing the body the most at the moment is the addiction to the substance use, they might need an acute detox setting to start them off. If it's the eating disorder symptomology or the state the body's in because of the eating disorder, Then eating disorder medical stabilization is where they should start off. And that doesn't mean that the medical stabilization doesn't have the ability to do the acute detox. I would say there's probably more options to do acute detox for, well, I know there are more options to do acute detox for substances. And so eating disorder medical specialty units that stabilize people for the medical complications of eating disorders have had to start adding, like, here's what we need to do for detox too. But it may be hard to find. So sometimes, depending on where you are and what your hospital can treat, you might need to start at one place and then go to the other. Here's where we have the most progress to make in terms of integrating care on the medical side. And I know the physicians want this too. So hopefully we will start to see a lot more programs that can start to do both. And then we have our treatment centers, or in your outpatient settings too. You can think about this in terms of what do we have to do behaviorally that is different with eating disorders than with substance use. So in an eating disorder setting, and even in your offices, that you have to be thoughtful about how are you going to support this individual with food planning. They might need some meal support. If they're in a treatment center, the staff would be trained in that. If they're in an outpatient setting, adding recovery coaches or eating disorder coaches and dietary support for planning and meal support. In my office building, actually, even in my outpatient practice, I thankfully have a bathroom monitoring situation where you have to use a code to go into the bathroom. So I know when my clients are needing to use the bathroom, if they're struggling with purging or struggling with behaviors in the bathroom, that I will walk them to the bathroom that is locked and enter the code in. And in treatment centers, we have all kinds of ways to monitor bathrooms, whether it's having a bathroom monitor or places where you're asking them to be outside of the bathroom for a period of time after they've consumed food to reduce the urges to purge the food right away. And then when you're working with folks with eating disorders, you do need to have the ability to do medical monitoring for them. Oh my gosh, can I just say the issue with weight and eating disorders has really been kicked up lately. Just into maybe it's the start of the school year or something like that, that a lot of folks have been complaining about going to their medical providers and asking not to see their weight, and then being handed, that's a blind weight, not seeing your weight when you're weighed, and then being handed like their discharge slip or going into their portal. And, as one person said, I see my name, my date of birth, and the next piece of information is my weight. And seeing a weight can be very triggering for someone with an eating disorder, and that needs to be managed well. If you're in an outpatient setting, I'm not opposed to them knowing their weight, but at what time? It's not a when, it's it's not an if, it's a when. When they're to the place where they can handle that information without it triggering a return to eating disorder behaviors. And then oftentimes folks with eating disorders have medical issues. You need to be able to, whether it's in your treatment setting or in your outpatient practice, have them get vitals, how's their heart rate doing, and lab work on their, make sure that their blood work is okay. It's always important to gather information for folks with eating disorders and how their body is doing, because like folks with substance use, they're not reliable reporters on their own behaviors. Now, I'm not saying that individuals are purposely lying and trying to deceive us. It's just their perspective of what they're doing is different than ours. So we collect objective data. With substance use, you would be, of course, getting urinalysis, toxicology screens. And so you want to be able to do that with your clients in eating disorder treatment as well. Also, maybe, doing testing the urine for specific gravity to see if they're dehydrated or they're overutilizing water. So if you have a program that's treating substance use and you want to treat eating disorders, these are some suggestions to start to think about to put in place. You do have to change the environment. Oftentimes in substance use programs, there'll be like a community kitchen with access to, cereals and snacks and stuff like that. That's really hard for someone who struggles with an eating disorder to have that free access for food. So there might need to be a reworking of that. Maintaining factors. Oh, and just to my co-hosts, we have somebody who has a hand raised that if you want to see if you can help them in the chat. So let's talk about understanding what skills we need to help them with, and what are the maintaining factors of what they do with trying to take themselves out of their bodies, which is basically what both having an eating disorder and using a substance is. I don't want the experience of what I'm feeling in my body, and I want to be taken away. So we were thinking about what function do their behaviors serve and how to increase competence with emotions and triggers. This is the therapeutic work. So some functions of behaviors of eating disorders and substance use. Avoiding unwanted internal experiences, and what they're doing with food and substance is an attempt to solve a problem that becomes a problem. And this is from Stephen Hayes, who founded Acceptance and Commitment Therapy Act. I also like Internal Family Systems, IFS. Their perspective, Dr. Dick Schwartz's perspective, is that eating disorder behaviors and substance use behaviors are often what's called a firefighting response. So the emotional system is overwhelmed in some way, and the firefighter comes in with the substance or the eating disorder behaviors to douse the flames of that feeling of overwhelmed, even if there are consequences to using that firefighting technique, right? So that it's so dire that the person feels like internally, my anxiety is so high and my depression is such in a pit that I need to use these behaviors because I don't know what else to do. My pain is so great. I'm willing to suffer the consequences of what I know these behaviors might bring me. So, but in both cases, what is the function of behaviors? To manage pain inside. Whether that's pain because of biologically based mental illness like depression, and oftentimes both substance use and eating disorders, you will find trauma, a lot, and oftentimes very extensive trauma in their background. And then another thing we can do is to increase emotion competence and experience with triggers. Now, it's not just the individual who's responsible for this, but it's us as caregivers, whether we're caregiving as clinicians or as family members. I love Della France's model of EFFT, Emotion-Focused Family Therapy. I've got a reference for her book in my reference section, and you do not have to be a clinician to employ this model. So it's taught to caregivers, social workers, nurses, school educators, where we use our relationship with the individual to help them co-regulate their emotions to improve competence and confidence with having emotional responses. And for those of you who've treated substance use disorder, eating disorders, or both, you know that a lot of times the using happens after something that's overwhelming that's happened for them. So how can we work to increase through emotion coaching and behavior coaching the individual to feel like they're validated and that we get it and understand their pain? I just want to put a little reminder in here that what's the most effective thing that we can do therapeutically to help our clients? It's the relationship with the clinician. Decades of research has found this over and over again. So if we can understand them, see them, validate their emotional responses, and with loving emotional support, provide them then with some redirection or suggestions or problem solving or skills to help them, we will do well in helping them move forward. But it doesn't happen, according to EFFT and Bonnie Brennan too, it doesn't happen without first being able to see, understand, acknowledge, and validate that they have pain, real pain, and challenges and emotions that are getting in the way. When these emotions are triggered, it often sends the brain into that limbic state of fight, flight, freeze, or fawn. Some of you might not know what the fawn part is. Fawning means the people-pleasing behavior or the attempt to like, okay, it's okay, I'm going to like do what you say so that I'm not in trouble. So when we're triggered, usually it's something that triggers us emotionally, that sends us into the limbic state. And then it's in the limbic state that we tend to go to those firefighting behaviors, or we might feel the symptoms of anxiety, depression, use of eating disorders, anger, that sort of thing, that then we are trying to like act to get rid of, right? So understanding that triggers are often emotionally similar content that happens, could be directly similar content, but most often it's emotionally similar content that may or may not have to do with the actual content of what is happening. So you can be triggered by something that seems like it's a similar situation, which in reality it's very different, right? But we still have to help the individual with how to reduce the impact of the triggers. And this is done by building a sense of internal locus of control, the feeling within inside the person, and back to that competence again, that they are competent and can actually build resilience no matter what their system tells them is painful, or to be, even if it's their temperament, like back to those temperament characteristics with eating disorders, even if it's a temperament trigger. So what are you recovering for is a question that is so important for both populations. For those of us who are treating the younger population, this is a hard question to answer because they haven't had maybe a lot of time in life to experiment who they are, what they want their life to be about. Or like in my beloved 50+ population, they maybe have spent their whole life for everybody else doing the things they needed to do for their job or for their kids or for their family system, and never really built an internal sense of who they are and what is important to them, how they want to share what's important to them with the world. So doing this is hard because you might have to do some experimenting and have some feelings of like, I thought that was my whole 20s, by the way, like, I think I want to do this. And then like getting really close to it and being like, oh no, that's not for me. I don't want to do that thing. So that's kind of a trial and error if you haven't had much time in life and building what you're connected to. But a little tip is you can use what you tend to find emotionally painful as a clue that there might be something that's important to you there, right? Like, so if you're frequently complaining about not being understood in relationships, then you know that what's important to the individual is, I really need connection and understanding from people. And I want to find a way to do that. We also want to spend some time, and oftentimes as clinicians, we're really focused on like, let's get rid of the problems and then we'll figure out the other stuff later, right? But if we don't help our individual to walk into the real world, actually have relationships with their family, so cutting off family members is not something that that I would do lightly, that in some old models, that was the belief, we had to take the individual away from their family because they were the cause of things. Having appropriate family support, EFFT has a lot of caregiver support for individuals. You can get that book, for example. And also helping them to build social, educational, and occupational goals so they can start to walk into life, and maybe under the, expanding that repertoire of things that are possible for them, see that there are other options to engage themselves and help them, even if they have pain inside, to also make room for joy, for connection, for intimacy. You can have both. You can have grief and love at the same time. So what I propose is we think about models of conceptualizing care and what we do with the person that we're working with an eating disorder and a substance use disorder and all the things, with an umbrella model, with which we can insert other types of therapies and skills and experiences. And so I'm going to review these umbrella models quickly because I know we'll be getting short on time. And I'd love to do more in-depth webinars on all of these. So umbrella models: acceptance commitment therapy, ACT, a relational cultural model, and nutrition therapy. ACT has over 1,040 randomized controlled trials to support its efficacy in all kinds of populations, from smoking cessation to eating disorders to autism to ADHD. And what it provides is looking at what are the processes by which a person gets well, rather than how to not do the thing that you don't want to do, right? So it will establish what are the adaptive processes that we can do to help the individual to move into wellness. So we want to add those. And, I was so guilty of this as a clinician before I found this type of perspective, of spending all my time, like, as soon as we get this problem solved, and the individual is going to be able to find their way into the life that they want. And I would really neglect the reinforcement, the goal setting, the exploring of the things that could actually help that. Maybe I would rapidly do that as if I was in a higher level of care, as like a discharge plan for the individual. But we really need to start with it on day one. What are the things that this person can do that help them get well? And ACT, there's 6 core processes that help to guide the clinician, and you can use lots of scales and measuring of this, guide the clinician with how to support them in terms of mindfulness, acceptance, values work, taking committed action, knowing the difference between the story in your head about who you are and then who you actually are in this moment in time, and then defusing or disconnecting from the things that you hold really tightly about yourself, the beliefs like, I can't do it, or this is just me. And I was talking with a client this week, and he was saying, like, this is just the way I am. I'm stubborn. I'm like, oh, okay, well, this is the way you think that you are. And maybe there's also a part of you that has some flexibility too. So we went with ACT. We're looking to increase psychological flexibility, identify that life worth living, and the behaviors that will take you there, slow down the present moment to the present moment without getting too far ahead or too lost in the past, and noticing our automatic reactions, and make space for unpleasant thoughts, feelings, and emotions, right? So if you're in the therapy room with the individual, you want emotions to be happening. I used to say a trigger is just evidence that there's an emotion present, and that's what we have to work with. Oftentimes we say, let's reduce the triggers, let's avoid the triggers, when we actually might want some triggers, right? And the trigger lets us know where is the work that needs to be done. And if we don't have some triggers, we're going to have triggers in the environment. So when the person walks outside of our office, they're going to be triggered left, right, front, and center with whatever it may be. Triggers for substance use or eating disorders are all over the place. So we do our best work when we help them to be able to be in the presence of triggers and not to have that response, that firefighting response of their eating disorder or substance use. My colleague Carmen Dominguez has recently been helping me with Relational Cultural Therapy, which offers a different approach to the medical model. So the clinician is not the competent expert delivering, this is what you shall do, and I am going to make sure you do it. Instead, it's both people getting to know each other, respecting that the uniqueness of the individual in front of you, also being able to share where your own empowerment with them. So it's not power over people, but helping them to have power with themselves. And there's if you haven't seen the proposal by Labrada and Bendit earlier this year, I think it was February, with a link in my references. Take a look at this. They propose relational cultural therapy and self-compassion as two ways to serve marginalized communities. We can do a better job in working with more diverse populations, especially in the domain of eating disorders. So we want to help the individual to work towards authenticity. Who are they? Who is their authentic self? And a lot of folks, I was talking about this with a client this week, and she just had tears in her eyes. She said, nobody's even cared who I am. I've always had to change that for my family, for my work, for my sport. And then how to empower that person to be in their authenticity with themselves and with other people. And in particular, especially the case of eating disorders, this inauthentic self, eating disorder comes in, right, to try to control them and isolates them. And those of you who work with these individuals full time know that they kind of tiptoe into treatment, worrying about who will like them, how are they going to connect? I'll be the only person that feels this way. So moving them out of isolation and into relationship is super important. That starts with us. And ACT has a nice way of saying this. The therapist is on their own journey, or the clinician is on their own journey, and the client is on theirs. We're two mountains. But from my mountain as the clinician, I can see your journey at a different perspective, but we're both climbing at the same time. Nutritionally, whether it's eating disorders or substance use disorder, we want to work to normalize intake, have education about emotional and physical hunger, practice awareness around our relationships with food, mindful eating. Why would I or wouldn't I with a particular food item? Build awareness around judgments of food, and incorporate the no good food or bad food philosophy. Now, I know this for some substance use programs, this might be, or those of you who are used to proposing a certain type of diet in your work with substance use disorder, this one might be challenging, right? Because there are beliefs about the prescription about how you should feed your body in your recovery from addiction. But when we're treating both, I would venture to say, even if you're just treating substance use exclusively, to help with this idea about no good food or bad food, because you might inadvertently trigger eating disorders with food rules that you apply to substance use treatment. So we're incorporating a variety to assist with deprivation thoughts and assisting with navigating goals based on values versus weight loss goals or dieting. And so we use these umbrella models. We've got the relational cultural theory, acceptance and commitment theory, and the nutritional therapy. And then here we have all the other stuff that can be inserted. So you want to find resonance. There's no current evidence-based treatments or protocols for treating eating disorders and substance use together. We don't have any evidence-based protocols. So we are tasked with finding a way in to help individuals heal. For those of you who want to take this to the next level, I recommend you take a look at Hayes and Hoffman's work on process-based therapy. There's a book, Process-Based Therapy, which is essentially a way of like mapping out what the individual's maladaptive behaviors are and adaptive behaviors are, and understanding the individual as a whole rather than doing a protocol-based approach, and helping insert evidence-based therapies and modalities to heal the individual. And this helps us to expand our repertoire of healing. So just for example, here are all the things that we can do, right? Like Integrative Life Network can do these things, and you might be doing these things in your practice. And if you're already doing them, I challenge you to like take it the next level up. Like, what is the umbrella under which that I'm believing the individual can have healing? And when we do that, then it's really the education about how to not have a substance use disorder, how to not have an eating disorder. It's just part of the puzzle, right? So we can really insert that. You can build your skills on that if you have one expertise and not the other, and know that everything that you do can fit under these umbrellas and help the individual towards health and wellness. Another thing that I've noticed over the years is what works for one person doesn't necessarily work for everyone. So it's nice to have places for them to experience that they can touch base and something might click for them in their brain. Whether it's doing trauma work, some folks, especially folks with eating disorders, might tend to want to have a more like scripted approach, like just give me the roadmap to get myself to wellness. I would still poke them around into emotion competence as well. How do I develop a different relationship with my body? How can I use other experiential stuff to maybe pick up some of those triggers so that we know what we're working with? So we are at time. It is now time for questions, and I'm happy. I know I threw a lot of high-level content at everyone, so I'm happy to start to entertain questions. And that's a picture, a lovely picture of Cato House.
Cato House. Bonnie, thank you so much for the presentation. I really love that you put a different slant on how to treat eating disorders and substance use at co-occurrently. So thank you so much. It is now time for questions, and we have a lot of questions. I just want to remind everybody that this presentation is sponsored by Cato House at Integrative Life Center, and Cato House is an 8-bed residential facility for women out in West Nashville. And if you have any questions about Cato House, please feel free to either you can either text me, best text me, opposed to calling, or email me. I would love to answer any questions, or I'd love to set up a time to speak to you about them. The first question that we have, Bonnie, is just if you could please repeat the name of the person who developed the temperament characteristics.
Robert Cloninger. So Robert, as you know, it's already spelled C-L-O-N-I-N-G-E-R.
Thank you.
The name of the measure is the Temperament and Character Inventory. And if you do a Google Scholar search and put in TCI or Temperament and Character Inventory, you'll pull up a lot of content.
Thank you. We have many questions, and just to let everybody know that we will do our best to get through them. If we don't get a chance to answer your question, please watch out. I'll have Bonnie create a video and place that on our website, or maybe Tara, we can send some Q&A unanswered questions out to everybody who has participated here today. I think that would be the best. So here's the first question. Could you please address helping a 50-year-old female? And Bonnie, just heads up, I think that this is for a case, 50-year-old female who has diabetes and is reluctant to eating mindfully. She misuses her insulin, results in low blood sugar and TBI, oxygen deprivation. And she is also a heavy cannabis user.
It sounds like a really challenging case. And so I guess the first thing, and I'm not sure the training of the clinician, but if it were me, I'm not trained medically, so I would want a good physician who has knowledge of diabetes to be on the case to make sure whatever that we're doing, I'm not sure how she's using her insulin management, but to make sure that the body's stable enough to be in a place to be able to do outpatient work, right? So, and with substance use and eating disorders, always having that team of the medical professional that to have collaboration with. I will not work with someone who refuses to give me medical data. Like, I need to be able to know that this person is safe to work with in an outpatient setting. And then if not, looking at programs that might be able to take because that's very serious. It can be very serious and life-threatening illness to be having a quasi-eating disorder problem there. I don't know if it's a diagnosed eating disorder or just a manipulation of insulin or not using it, and then combining that with marijuana use. So I hope that answers the question.
Thank you. A lot of people are really loving the temperament work that you were talking about, Bonnie. Right. I appreciate what you wrote about the temperament similarities between patients with eating disorders and substance use and what helps explain why clients might have both. Do you have a sense of why some patients do not have both? In particular, what separates patients with eating disorders who do not have substance use disorder from those who have both?
That's a really great question. I can only answer anecdotally. So we know that the bulimics will tend to, because they have high novelty seeking and high harm avoidance, they have more substance use disorders. I would venture to guess that this is because of the impulsivity. Just knowing the population anecdotally, these are often individuals that they want to have some fun, they want to have the experience of life, but yet they have this temperament characteristic that says, but don't get in trouble or you're going to blow it. And then they feel out of control, and then the restricting or the anorexia part tends to crank up. So they go back to that high harm avoidance thing, and that gets boring. Then they go over to novelty seeking, and it creates a chronic state of anxiety. When part of your brain is saying, go have fun, and the other part is saying, better not get in trouble, it's like, what should I do? What should I do? What should I do? Is this the right choice? Is this the right choice? Over and over and over again. So state that question again, Robin, because that was such a good question.
Yeah, and I think it would be great for us, Bonnie, to pull up, see if we can find some research on that and add to future presentations, because that's a great question. So do you have a sense of why some patients do not have both? In particular, what separates patients with eating disorders who do not have substance abuse from those who have both eating disorders and substance use disorder?
I would guess that it is, my educated guess on this is that the high harm avoidance is so high that they would never do anything to get them in trouble. And substance use is seen as getting in trouble, right? Like, it's bad, or calories in the case of an eating disorder client. Right?
Yeah, thank you. Thank you so much for that question. And we'll get some studies. We'll find some studies on that if possible. Okay, another question. Any resources on nutrition therapy? Many nutritionists aren't sensitive to eating disorders, and it can further trigger disordered eating. I think before you answer this question, Bonnie, I would like to add that in regards to an eating disorder, it's important to look for a registered dietitian opposed to a nutritionist. And over to you, Bonnie.
Yeah, so certainly there's, in fact, I think there's conference with the food and nutrition education, the FNC, for folks in the dietary field coming to Denver, which is close to where I live, this October. But yes, I absolutely recommend for a dietitian to have education on eating disorders. You can do this a number of ways. There's a pathway through the International Association of Eating Disorder Professionals to get nutrition education. A lot of dietitians will do internships or time and working in an eating disorder program to learn and mentor under individuals with that. But if I'm forgetting another pathway, Robin, please jump in. But those are the two most prevalent ways to get education about eating disorders, but to make it part of your experience as you're getting your degree, or to seek it outside through credentialing.
Yeah, and I think the resources is on nutrition, like trying to find people that specialize in it to support the clients, because and so as I said before, I think it's important to evaluate the person that you're seeking guidance from. Nutritionist does not need to know what a registered dietitian will know, and they're the best person to seek help to support your eating disorder client, or your client with an eating disorder. Also, there is such thing as a certified eating disorder registered dietitian. So you can look up Psychology Today and look up a registered dietitians, that is CEDS, CDS. That would be really great. And then the other platform you could go to is the National Eating Disorder Association. That would also help you. So thank you so much for that question. Here's another question for you. We have so many, Bonnie. How do we navigate the rigidity of most service providers and advocate for harm reduction approaches when service providers are rigid and believe their way is the only way? The consequences for not complying with the dominant treatment approaches can be traumatic for clinicians, with losing their employment, particularly in high levels of care or compliance against them. Yeah, over to you, Bonnie. I just would like to honor this by saying that we are aware that at least 80% of those 80% of substance use facilities are navigated by a 12-step model. And so I think that this is a very important question, Sandy, and thank you so much for asking this, because we do know that harm reduction actually is one of the top evidence base, if not the top evidence base for substance use disorder treatment. Over to you, Bonnie.
Yeah, so I think the question was, how do you navigate working with other professionals and in work environments? So I'm going to propose that first we look to that emotion-focused family therapy. So the individual who is being rigid, or the organization that's being rigid, is usually not going to respond very well if your power is struggling with them, right? So they have to know that you understand their point of view and maybe their emotional responses around that point of view, and then work to collaborate together. And then at some points, and I've certainly worked with individuals who've had rigid, sometimes are my favorite folks, like if I'm working with sorry, dietitians, if you're listening, but in general, the dietitians I work with tend to be more detail-oriented and more goal-focused. And I'm like, oh, they had emotions. Who cares if they didn't meet their goals of sobriety or eating disorders? At least that's how I think I'm experienced. So I work with them to understand what's important to them, and also to emotionally validate, like I get your perspective and I hear where you're coming from, and then be more collaborative in the process of, here's what we can expect from this individual, and yes, maybe we would want ultimately this to be the case, but what if, despite all of our best efforts, we can't get that? Are we giving up on the individual? What then? If this doesn't work, then what? And then how can we be prepared that the individual might not respond well to the rigid approach, yet still continue to work with the individual? I really don't believe in giving up on individuals. Sometimes somebody has a situation that's beyond my competence or beyond the competence of the treatment center because of a medical issue or some other challenge psychiatrically. But I don't ever want to have the individual leaving an environment believing that they are a shameful human being who has failed. So always building on the successes that we have been able to support, giving those to the individual, not us, not our button of like, I was the healer and I deserve the credit. It's the individual gets to wear the badge of the like the birthday button, right? The birthday button of recognition, giving that to them because it's our job to help them to be competent and independent in life, not dependent on us to dictate what they need to do next. Hopefully that answered a little bit of that question.
Thank you, Bonnie. Can you suggest any websites or particular courses which therapists can sign up for free or affordable price for learning relevant therapies related to eating disorders? Well, I know that we are going to be offering many webinars for you that will walk you through acceptance and commitment therapy and the likes that I know that Bonnie is very passionate about. So please reach out to Tara if you would like to be put on the list for free webinars. I'd also just like to say the Eating Disorder Coalition, I think, offers free websites, free trainings.
Yep.
Bonnie?
There's a number of low-cost and free resources for eating disorder training, and if you get on their mailing list, you'll see things like you did for ILC's free webinar. That would be the National Eating Disorders Association, which Robin mentioned. There's the Eating Disorder Foundation. There's the Alliance for Eating Disorders Awareness. And there's ANAD, which is the, help me with it.
Association of Eating Disorders, I think it's something like that.
And
I don't know.
And I think it's anorexia nervosa and associated disorders.
Oh, sorry, I'm thinking of AED.
Yes. And then there's the Academy for Eating Disorders. So there's lots of learning opportunities. And then, of course, there's IADEP sometimes has some free stuff, but usually that's a pay, folks do some kind of pay. We have a local IADEP chapter in Colorado that will do webinars that are like $15, $20, so they can be low cost too.
And I would love to propose now, since this is something that Bonnie and I are so passionate about, is getting education to professionals who really want to make a difference in the way that they treat eating disorders. If you have an idea of some information that you want to receive or some training, let us know. Yeah. So that we can provide those trainings for you here. We would love to be of service in that way. Next question. In duly diagnosed people with eating disorders and substance use disorder, at what time do you generally recommend a deeper dive into the trauma work? Great question. Thank you so much, Amy.
Yeah, so I want to know, I assess everybody that I see for trauma day one. So you can do that using the PCL5, which is a screening assessment for trauma, and it'll give you an idea about the presence of traumatic events for this individual. The challenge with folks with eating disorders and trauma work has always been, because they are so experientially avoidant and emotionally, I don't mean this to be shaming, but incompetent, not wanting to have competence with emotions, that if we move too quickly into traumatic events or the retelling of traumatic events or trying to process traumatic events, they may quickly do the firefighting response and stop eating or engage in more throwing up behaviors. So you have to go gentle and slow, and sometimes it's just through that process of emotion validation, helping them with, like I've spent some time with helping individuals just be able to name that what happened to them actually was traumatic. And they want to, dismiss it and, no, other people have had it worse or hard. just seeing the change on their face when my face shows them, oh my gosh, I'm so sorry that that happened to you. So I start with it right away. Doesn't necessarily mean that's the entire focus of our work, but we want to help them to build trust and safety within the therapeutic relationship to be able to move into a place of doing that work. So you're starting trauma work right away with knowing that it's there, being able to validate it, building up trust, loving connection, and human understanding with the individual.
Thank you, Bonnie.
Yeah.
I'm going to ask this question next just because I've had a couple of people ask it. Can you please address ARFID treatment? I'm seeing this more and more and would like to know what the best course of treatment is for this type of eating disorder.
Yeah, ARFID stands for Avoidant Restrictive Food Intake Disorder. We don't tend to see a lot of ARFID in substance use, but that doesn't mean that it doesn't happen. We just don't have data on it right now. And this is an eating disorder that develops not because of body shape, weight, and size issues. It develops because of a number of different reasons outside the scope of this presentation, but in general, because there's sensory processing disorders, there's a traumatic event where somebody had a fear of throwing up, for example, emetophobia can cause avoidant restrictive food intake disorder, but it can be a belief about if I put food in, bad things will happen, but it's different than the person who's managing the body weight, shape, and size considerations. So they're restricting all food or groups of food to manage something else. And I have a case with an individual who used it to actually, she would have involuntary vomiting because of her intense emotions inside. And so she would be afraid to eat because she didn't want to have to vomit.
Great. I hope that answers your question. Here's another really great question, and I'm just checking the time. We have 10 minutes left. Bobby's saying, I work in addiction treatment center that is seeing a lot of eating disorders as well. The program is only 4 weeks long. How can we make the most impact in the short time frame? Such a great question. Are there any resources we can provide to begin this work with them?
Yeah, that's a really good question. And in 4 weeks is usually when people are just getting on board with changing so I just want to first pause and say, typically the path to wellness with food and body is going to be a lot longer than establishing a course of sobriety, right? So the typical addictions model, 4 weeks model, that's enough time to get the body off the substance. But because eating disorders, substance needs to keep going in, and their method of maybe controlling it is still there, food and body, it takes a long time. So the way that you can work within a short period of time is to help the individual identify those functions of their behaviors and what are the maintaining factors. If the program is open to making some changes to better support the individual around how to do their food, and if there's purging or exercise behaviors, how to support them to not engage in those, that's even better. But they're probably not going to complete a full course of treatment. An average residential stay for someone with an eating disorder is about 6 weeks to 3 months. And there's PHP levels of care too that they can step down to. But typically we're not looking into a discharge to outpatient treatment if somebody's had a more serious eating disorder for several months. It's longer than addiction treatment. So they might need some support following the substance use program with some specialists.
Yeah, I just wanted to add to that is that it is great to be able to, like Cato House, how we treat them co-occurringly together at the same time in the same place in a residential care. However, studies also show that if a substance use is a primary substance, okay to treat the substance use and then refer them out to an eating disorder residential treatment. And when it comes to insurance, just so if everybody knows this, is that your substance use disorder insurance is very separate from your eating disorder insurance. And so, you know, if we need to, that is the best kind of way that we can do it. If you discover that eating a substance use, treat the substance use, and then instead of sending them home or to a lower level care, refer them to an eating disorder residential facility.
Yeah, that's a good thing. And for those of you who don't do the eating disorder, or who do, a colleague of mine, Dr. Ken Weiner, used to always say, there are no eating disorder emergencies. There are medical and psychiatric emergencies, but there are no eating disorder emergencies. So as long as you have a backup plan, should the person become medically unstable or psychiatrically unstable, somebody having an eating disorder in your substance use program isn't necessarily emergency. It may feel like that, right? But if they're not medically or psychiatrically unstable, or I hate to be crass, ruining the plumbing for the other residents, there might not be an emergency. And just like you said, Robin, then having them follow up with care afterwards.
Yeah. And also the other thing too, unless you start seeing evidence of when they've put down the substance use, you start seeing evidence of maybe they're leaving their table, you know, immediately after they've eaten, or there is things that show you that, you know, they are actively purging, you know, then that becomes kind of a red flag that you may need to get them into eating disorder residential treatment faster than you had planned originally. The next question, so conscious of time here, we've got 5 more minutes. Christy's asking, are attachment theories and temperament related?
Attachment theories and temperament. Yes, I want to say yes, but I'm not that great with that recall memory that some people are so good with, right? So there's, so definitely, you know, so for attachment theory, we have like the anxious attachment and avoidant attachment. And so my mind is telling me yes. I don't have the data for you in my head at the moment, but it's kind of similar stuff, isn't it? To understand how temperament you can't change, though. That's where it's different than attachment. You can build secure attachment. But with temperament, what we learn to do is manage it. So if the brain is naturally, like my sister, very harm avoidant, is going to think of all the ways that things could go wrong, you can help them to manage it by also having some perspective of, but why would you want to do this, even if there could be things that go wrong? Help them with building self-directedness into doing things that their temperament might be a little bit like scared about, and vice versa for the person who's high novelty seeking, like maybe right now isn't the best time to go to Burning Man. So hopefully all those of you who are there are going, you're going to have a great time. I'm just using it.
Okay, I think that we're going to give this as our last message. This is from Irma. What is the current statistics on males versus female with eating disorders and with co-occurrence? Have you seen a change with a high percentage either way?
Yeah, so the binge eating disorders has the highest prevalence in males. And in general, in the eating disorder population overall, we see about 10%. I believe that's way underdiagnosed. But the most prevalent eating disorder in males is binge eating disorder.
I read a study a couple of months ago that 57% of men with binge eating disorder also have substance use disorder. So that's a massive statistic. I have to find that study, but I actually think it's in one of our the ebooks that we have created. Anyway, Bonnie, thank you so much again for presenting. And Tara, thank you so much for supporting the chat and for making this presentation happen. Once again, my name is Robin Cruz, and I am the National Eating Disorder Advocate for Cato House at Integrative Life Center. If you have any questions about Cato House, I would love to answer them for you. And thank you for being here and for all you do for the community. Thank you.
Bye, everyone. Thank you for being here.
Bye.